Hello, and how are you? Welcome to another session on lung cancer, focusing on treatment and management. My name is Winnie Barawa. And again, if you're new, we are doing a series on lung cancer. We have explored classification of lung cancer. We've looked at the causes, risk factors, and diagnostic management or diagnostic methods of how to find out and explore on the cancer types. So on this case, we are going to focus on the treatment and the management aspect of lung cancer. So stay with me as we progress. So the lung cancer management, we are going to look at medical treatment, and then we will explore on the nursing care management. So on the medical treatment, or rather the main treatment modalities for cancer, we have surgery, radiotherapy, chemotherapy. Alongside the three managements, we have other treatments that are normally combined together, and this includes immunotherapy, hormonal therapy, biological therapy, which could also include stem cell transplantation or stem cell transplants. So here is a list that is explaining the priority management for our cancer patients. And here we have different options: hormonal therapy, surgery, bone marrow transplant, which is basically referring more so like stem cell transplantations. Then you have chemotherapy, targeted therapy, radiation therapy, including immunotherapy. So this is to just highlight the main treatment management that we can give for our patients. So starting with the first cancer management, where we talk about surgery. Surgery, most of the time, it's taken as one of the main treatment we give if a client is in the first stage of lung cancer or in the second stage of lung cancer. If you've not watched our videos on staging of lung cancer, you can find it on our list also and refer into it so that you understand what we mean by stage 1, stage 2, all the way to stage 4. So surgery, we do it mostly if you're targeting removal of all the involved tissue while preserving as much functionality on the lung as possible. So there are different surgeries that you can do, but the main one, we call it the resection, that is cutting and removing the localized tumor. So in this case, we use it mostly for non-small cell cancer patients or non-small cell lung cancer patients, and it can include procedures like lobectomy. So lobectomy is the lung cancer surgery where we are removing single lobe of cancer, where if the cancer is contained in one particular lobe, we can remove the affected lobe. So the lungs have several number of lobes. If you're on the right, we have 2 lobes, and on the right we have 3 lobes, and on the left we have 2 lobes. So with the lobectomy, basically what we do is we handle the single lobe that has been affected, or we remove the single lobe that has been affected. Then we have bilobectomy. Bilobectomy is removal of 2 lobes. So 2 lobes of lung can be removed that have been affected by cancer. And we are told this only happens on the right side of the lungs, only on the right side. But we can also have sleeve resection. Oh yes, before I leave bilobectomy, we are told it happens only on the right side of the lung because it's only the right side of the lung that has 3 lobes, unlike the left lung that has 2 lobes. So you cannot remove all the lobes, and that means we will have to do lung transplant. Sleeve resection, on the other side, is whereby cancerous lobes are removed and a segment of the main bronchus being resected. So in this one, we are removing the lobes, and we are also removing partly some of the bronchus areas. And then we have other surgical procedures that we call pneumonectomies. So in pneumonectomy, the entire lung is removed. Basically, if the tumor is so big, it has spread out, and we are almost heading maybe to stage 2 in the late stages or stage 3s. Then there is segmentectomy. So segmentectomy removes a segment of the lung, or a segment of the lung is removed. And then we have wedge resection. So in wedge resection, there is removal of small pie-shaped area of a segment. We don't remove the whole area, we just remove a segment of the lung, but a small part of it. Then we have the chest wall resection. With chest walls resection, they happen when we are worried that the chest walls have been infiltrated by the lung tumors and the tumors are attached on the walls of the chest. So you can have resection also taking place in these particular areas. And the second option of treatment is what we call radiotherapy. So with radiotherapy, we are using radiation rays, where we say we use high energy ionizing rays to destroy cancer cells' ability to grow and multiply. So here we want to limit the ability of the cells to grow, or we eliminate the ability of these cells to grow and multiply. Remember, in cancer, cells are able to multiply to produce an effect we talk of as hyperplasia and dysplasia. So to limit those procedures or processes, then we can introduce radiotherapy. So how do we deliver this? We deliver radiotherapy via external beam radiations, or we can do intraluminal radiation or brachytherapy. So here we have our cancer patient. I just want to explain how this happen, or administration of the radiotherapy. So this is our radiation machine, and we are able to expose the radiation rays to our client, but we are targeting specifically where the tumor is located. So these are the rays, what you are calling the high energy radiations. This is the procedure where we are using external beam radiation therapy. So in external beam radiation therapy, we get to use the radiation machines, and we are able to expose the rays to the patient and kill the tumors. But now in the other options where we have internal radiation therapy, here we are able to target specifically where the tumor is, and then we introduce radioactive chemicals. So this can be done as brachytherapy, or you can have a systemic therapy that you introduce using IV lines. So when you're doing these two, the main target is to just address where the tumors are, and then you introduce the radioactive chemicals there to destroy the tumors or to limit their multiplication abilities. You can use radiotherapy alone, or sometimes it can be used in combination with surgery and chemotherapy. Most this is determined by the stage of where the cancer has reached. So if the lung cancer mostly is in stage 3, that is late stage 3, you can have a combination of surgery, chemo, and even radiotherapy all together. So it's important that radiotherapy mostly is used in controlling the tumors so that they don't spread out, and we use it mostly if the tumor can't be removed by surgery. So if surgery is not possible, radiotherapy mostly becomes the second option to use. And the agenda is to reduce the size of the tumor so that it can be at a manageable stage before surgery can be used. So it's used to reduce the size of the tumor, and after we've done radiotherapy, mostly we use radiotherapy to promote palliation or palliative care. So this will help us eliminate common symptoms of our cancer patients like cough, chest pain, dyspnea, and also hemoptysis. So just to summarize, radiotherapy is the procedure where we use high energy ionizing rays to destroy cancer cells with the agenda of limiting their growth and multiplication abilities. So it can be administered using external beam radiations or the internal beam radiations, not beam, sorry, internal radiation therapy. And in this, we can have either the IV administration or the brachytherapies. So you can use it together with chemotherapy and surgery, or you can use it alone. And the main agenda is to remove and control tumors that can't be surgically removed. And the agenda is to just provide both symptom elimination and palliative purposes. The other management we have is chemotherapy, and this is the third management for patients with lung cancer, which is like the main modality. So in chemotherapy, we talk about the use of antineoplastic or chemotherapeutic or cytotoxic drugs to alter tumor growth and treat cancer that has metastasized. So chemotherapy is quite effective when you're dealing with the metastasized cancer or cancer that has spread to other parts of the body, that is not just the lungs only. So we can use it both for non-small cell cancers, or we can use it for the small cell cancer. So there are some common chemotherapy drugs that are very commonly used for the management of these cases. And for the non-small cell cancers, normally there's preference of using combination therapy of two drugs. So there's famously what we call cisplastins and the carboplastins together with other medications that can be the taxols or the taxoteres. They are mixed together to just handle the chemotherapy cases. In small cell cancers, we have common medication like cisplatins and etopoxides, which are part of the chemotherapy chemicals for use. So this is a demonstration of how chemotherapy is administered. You can administer chemotherapy either orally, or you can also administer it via IV line to just allow the medication to come in and attack where the cancer cells are. And our target here is the lung. So the IV medications or the chemotherapy drugs through the IV line will find all their way to the lungs, and then they target where the tumors are and destroy them. So there are common chemotherapy medication. It's a huge list. And in this list, there is first line medications and second line medication, depending on the progress of the patient and how they're responding to the management. So we have all the way from etoposide, paclitaxel, there's so many. Like I can't read all of them because of the names, but we have all the way to methotrexate, all right, all used for the purpose of chemotherapy. So we have several types that you can use. They can be used mostly preferably in combination therapy, where you get to have one medication combined with another medication for the purpose of stability and effectiveness. So someone might ask, when do we give chemotherapy, and how is it given? So let's start with the when. Chemotherapy can be used in combination with other modalities of cancer management, and this administration of chemotherapy can be done, for example, before surgery, it can be done after surgery, or it can be done generally to manage a chemo patient or a cancer patient. So before surgery, the chemotherapy here, we normally call it neoadjuvant chemotherapy, and the agenda is to shrink the tumors to make it smaller before it can be resected in the surgical procedure or sessions. And after surgery, we call that chemotherapy adjuvant chemotherapy. So the adjuvant chemotherapy is used to just kill any other cancer cell that is left in the system, and you want to clear it away from the blood. But you can also do chemotherapy to manage locally advanced non-small cell lung cancers, which are strongly spread out in the body and you want to get rid of them. But then we have the metastatic management side, where if a client is in stage 4 and there is extreme spread out of the cancer cells all over the body organs, from adrenals to the kidney to the liver, the brain, and even the neck, you'll have need to use chemotherapy to just calm down the situation or to kill the cells from the different areas that have spread out. So previously I had mentioned that chemotherapy medication can be given different methods. It can be via IV lines, or it can be orally given depending on the cycle that our client is on. But chemotherapy can be, most of the time rather, is administered via IV infusion, where it can be given through central venous catheter, what we call CVCs, or the peripheral IV lines, which is given on the arm. So what happens is, with chemotherapy management, mostly the patient can visit the center or the chemotherapy center. They're mostly given a site where they calm down, get maybe counseling before the procedure is initiated. It can take maybe hours or few days, or maybe it's not hours, but hours or some minutes before the session ends. So chemotherapy is given in cycles which last a given period of time, mostly like 3 to 4 weeks, but the chemo cycles are followed by a period of rest. This is to allow the body to adapt from the side effects. Remember, chemotherapy has side effects, and because of this management, it's normally advise that after every cycle of chemotherapy, the patient takes a period of rest before they resume for another cycle. So the medication can be given at a regular period. For instance, in a week, a client could go for 2 or 3 sessions of chemotherapy, and then they're given like 2 or 3 weeks of rest before they go for the next cycle. So it's important that clients embrace this period of rest because they help in allowing the body to regain their strength, to boost up their immunity, and to allow it to be strong enough for the next cycle. So the length of treatment mostly depends on the drugs that are being used for the chemotherapy sessions and the response of the patient to the treatment. However, I need us to note that when clients get to be on chemotherapy cycles, they'll be responding and there'll be response to this management. So if the client has picked up well and they're off the risk, they're off the severe stages of the cancer, then this client can be given maintenance therapy to keep the cancer in check so that we avoid cases of relapse or the cancer coming back. And in case the treatment fails, the patient can be recommended a second line of management or a second line of treatment. So we had said that when clients are put on, for example, chemotherapy, there are side effects that come along with the treatments, and that meant we have to allow the patient to go through a period of rest before we come back for another cycle of chemotherapy. However, chemotherapy is not the only treatment that has side effects, but also surgery, radiotherapy, and others can have the same. So we'll start with surgery and see the side effects that come along with it and explore the others. So in surgery, the side effects of pain. Client can also develop hematomas. There could be risk of hemorrhage because of the incision sites and the opening of the tissues, and the hemorrhage can actually lead to hemorrhagic shock or issue to deal with fluids, hemodynamic shock, and so on. Client can also present with altered respiration functions, could be because of the chest pains, they might not be able to breathe properly, or the client might present with labored breathing, and so on. There's risk of atelectasis, pneumonia, and even hypoxic cases. So surgery, because it's involving the chest wall, there's opening of the chest and tracing where the tumors are to resect them. Atelectasis is high chances because of collapsing of the alveoli that might happen. Pneumonia too is one of it because of the risk of infection, and hypoxia could be because of the altered respiratory function where our client may not be able to breathe in properly and leading to high carbon dioxide concentration in the body. There's also risk for DVT, deep vein thrombosis. Because of the bleeding, our client can develop blood clots that can end up blocking our main blood vessel supply in the body. On the radiotherapy factor or radiotherapy management, clients can develop fatigue. They could go through decrease in nutritional intake because of loss of appetite or side effects of the radioactive chemicals. There's also radiodermatitis. This is a skin reaction to the radioactive chemicals that the client is receiving, more so coming out more of like an allergic reaction. There's decrease in hematopoietic functions where the bone marrow is not able to form blood cells properly, and most of the time our clients can present with pneumonia. There's risk of pneumonitis. This is now the case where there's inflammation of the pleural membranes because of the irritation from the radioactive agents. There's lung fibrosis where our lung can form lesions or the lungs can end up with hardened fibrosis or fibrotic connective tissues and making it difficult for it to expand and relax as required during breathing and gaseous exchange. Plant also can go through grief, and this is a state of what they feel lost or they're not sure of how the outcome of the management will be. And on the side of chemotherapy, there is risk of anemia because of destructions of white blood cells and decrease in the hematopoietic functionalities. There's a risk for thrombocytopenia, and this is the case whereby there's an issue with the platelets where they become low, And we also have cases of low white blood cells because of the chemotherapy destroying part of them in the chemo processes, and the client could be at risk of infections. We have fatigue, there's alopecia, which is a state of loss of hair because of the damages from the chemicals again. There's cold and pale skin. This also reflects on anemic symptoms, tingling sensation because of nervous irritations and so on, irritability. The client again can give you dizziness and general body weakness. So these are part of the side effects that the client can present with, and there's so many others that maybe I've not included them on the list. Kindly remember to add them to your list. So other treatment for cancer can include immunotherapy. With immunotherapy, this comes in as a biological management for the cancer treatment so that we allow the patient's immune system to be stable. Remember, during management of chemotherapy, surgery, and radiotherapy, the client's immunity gets to be compromised, and this client is treated as part of the immunocompromised patients. And because of this, the client can be at high risk of getting infections, contacting other diseases, and even being unable to handle major conditions in their own bodies. So for this case, it's good we do immunotherapy by giving the client immune boosters that can promote their natural host defense mechanism and stimulate the immune system to be stable enough and to be capable of handling any other conditions that the client might have. And then the other bit is hormonal replacement therapy, which is mostly associated with the risk of decreased risk of lung cancer, and so it might have a protective effect on the patient. So we are told with immunotherapy, with hormonal therapy, we look at mostly hormones like the reproductive hormones that have a bigger role when it comes to the development of the lungs and maturation of most of the body organs. So for this factor, there's hormonal therapy replacements that could vary from reproductive hormones to growth hormones and any other developmental hormones that promotes the development of lung cancer. And the last bit is targeted therapy, where in this you can have biological therapy and stem cell transplantation. So in biological therapy, there are drugs that can be given which have the ability of detecting the proteins of cancer cells, leading to their damaging by linking them to the anti-cancer drugs. So with the monoclonal drugs, what they do is they will detect where the cancer cells are, they will hinder or inhibit their synthesis or their division, and then they will lead them into the anti-cancer drugs. And then these drugs can now destroy the cancer cells and eliminate them from the system. Then the other bit is stem cell transplantation, where we are told that it's unfortunate that the lung stem cells are one of the most capable of self-renewal and proliferation, and hence they tend to develop easy resistance to chemotherapy and radiotherapy. Now, with that happening, it becomes more efficient that during management we can do stem cell transplantation. That is, we replace the client's lung stem cells with new stem cells that are not affected with cancer and are not resistant to neither chemotherapy or radiotherapy. So apart from the main management where we mentioned surgery, radiotherapy, and chemotherapy, our cancer patient, we said, can also get other management, can include hormonal therapy, immunotherapy, and even targeted therapy. But there's some complementary therapies which are added advantage if the client can get them. This is to address any other issues that our client might have and might not have been addressed through the main modalities of treating cancer. So this could include acupuncture here. This is one of the management that explores the mind-body management for our patient to allow them to change their perception towards cancer, to accept themselves, and to embrace the management. This will allow us to have cooperation. It will promote positive outcomes in the management of this patient. There's also access to massage. This is a relaxation technique to give our patient more relaxed mindset, reduce stress, and lower any psychologically related complications. Can also give supplements such as vitamins And vitamins are known for reducing inflammation in the body, promoting immunity, and even lowering any status of infections that our client might have. Can go herbal treatments, food supplements, and complementaries, which are part and parcel of promoting the immunity of our clients. And of course, we have the mind and body approach. So, with the mind and body approach, the target is to reduce anxiety, promote mood stability or prevent mood disturbance, and also eliminate chronic pain in cancer clients. So, the complementaries are just happen to be there for the purpose of building up on the major treatments that our client is receiving. And now we are at the part of nursing diagnosis. So with nursing diagnosis, we are guided by, this will guide us in the final management that the nurses will provide. And one of the diagnoses includes ineffective breathing pattern, which is related to obstructive and the restrictive respiratory processes associated with lung cancer, evidenced by overexertion of patient during respiration. The second diagnosis is impaired gaseous exchange related to excessive secretions as evidenced by decrease in SpO2 levels. The other bit is imbalanced nutrition, which in this case is less than body requirements related to hypermetabolic state, taste aversions, anorexia, secondary to radiotherapy and chemotherapy management. And then we have risk for deficient fluid volume related to gastrointestinal fluid loss secondary to vomiting. This comes out strongly as a risk because when our client is on chemotherapy or radiotherapy, there's risk for vomiting, nausea, and all that, which increases the chances of our client losing body fluids and ending up in dehydration status. And another nursing diagnosis we have is activity intolerance, which more so is related to post-lung surgery. This is mainly because also pain and the general body weakness that our patient is experiencing. There's acute or chronic pain related to tumor effects, inversion of adjacent structures, and toxicities associated with radiotherapy and chemotherapy. There's anxiety, which is related to the uncertainty of outcome and fear of recurrence. We have anticipatory grief, which is related to the advanced diagnosis of the lung cancer and its management. Our patient can go through risk of infection, which is highly related to altered immune system secondary to effects of cytotoxic drugs, as evidenced by the side effects of the medication and drugs. Risk of disturbed self-concept related to changes in lifestyle. So this is a patient who is on chemo, possibly it's a new concept and doesn't understand how the whole thing works. So there's normally that risk for the disturbed self-concept. There's fatigue related to the chemotherapy management of stage 4, mostly, and evidenced by patient reporting low energies to engage in activities of daily living. So when it comes to the interventions, it's normally also advised we do that based on the nursing diagnosis that we've raised. And let's start this in order of how we've generated the nursing diagnosis. So with improved breathing patterns, we can intervene using proper positioning. I'm also advised to use the semi-Fowler's positions. Can go for humidification, which is aimed at opening up the airways by allowing dilation of the airways, promoting secretions of the secretions and mucus or sputum in the airways. Can give expectorants to remove any secretions that are clogged up in the airways and allowing them to come out. There's encouraging cough. Coughing is treated as a reflex that allows any fluids that are settled in the lower areas of the lobes or the lungs can be consolidated to come out. Can also go for deep breathing exercises. These are chest physiotherapy exercises that allow the client to practice the chest in opening and releasing itself, or opening to promote more chest capacity to take in more oxygen and eliminate carbon dioxide. We have chest physiotherapy as part of improving chest breathing pattern. This is done more so to allow clients who have difficult in breathing, to just open up their chest and allow more air to come in and out. Suctioning, this is removal of any secretions that are clogged in. There's bronchodilator medications whose main target is to prevent bronchospasms or bronchoconstrictions and to open up the airways. The oxygen is important because it's going to supplement for any hypoxia cases that the client could be presenting with. And the other bit we have is the impaired gaseous exchange. So for this case, if a client is a smoker, then you're advised to stop smoking or cease from smoking. And then we have positioning properly in the semifowler's position to just allow the alveoli to open up adequately and allow oxygen and carbon dioxide to exchange effectively across the surface. There is use of antibiotics to clear any infections that are spread out in the lungs due to the cancer. There is also hydration and medication. Fluids or fluid administration is known for promoting loosening of secretions or sputum and allowing the airways to be clear. There's deep breathing exercises again, which have the ability to expand the chest to its maximum, allowing for maximum inspiration volumes and maximum expiration volumes. Nebulization, this is administration of medications that aim at bronchodilation and opening of our airways, but also you can do suctioning to just clear any fluids that are limiting the surfaces for gaseous exchange. So the other management could be about chronic pain, and in chronic pain, we can use analgesics, which are painkillers that are able to lower the level of pain. Could include NSAIDs. Can also use massages. So massaging of the pain sites can allow blood supply back into the tissues around it and lowering the level of inflammation, leading to lowering of pain. There's comfortable position again, which allows the client to be comfortable, eliminate if it was any pressure on the site, the pain could be relieved. Health education allows the client to understand in details what the progress of the disease is, the way of action or the pathophysiology. This partly can lower the stress levels. Then improve on nutritional status. We can administer parenteral nutrition for patients who can't eat, but also you can look at symptom relief like anorexia and vomiting by giving antiemetics for this client. Then on the other management, we can look at the risk of disturbed self-concept. So this is more psychological, and therefore you can look at psychological support, encouraging family support, bring open communication where the client can communicate their disturbing areas or areas that are a bit stressful to them. Then you can clarify and allow the patient to have ability to understand. Then you can give diversional therapy, and this is therapy that allows the client to avoid thinking more or concentrate too much on the disease, which can lead to stress. Then there's promotion of self-awareness and assertiveness. So self-awareness allows the client to be aware of the progress of their disease, to appreciate their current changes that has come with the current diagnosis, and this will allow the client to be free with themselves, to believe in themselves, and to have a positive attitude towards the condition. Encouraging rest to conserve energy. This is because with the status of side effects from the management, the client mostly presents with fatigue, and for these reasons, you want to encourage enough bed rest or enough rest to allow energy conservation. For the issues of risk for infections, then there is need to monitor body temperatures, maintain proper hygiene, have balanced diet that has high calories and proteins, proper hand washing, and use of antibiotics in case the client has positive symptoms of infection already presenting. And then the other bit is deficient fluid volumes. In this case now, we can look at fluid intakes, that is allowing more fluid intakes, preferably orally, unless the client is really in a critical condition that you are not able to do fluids. But they're also allowing small frequent diets, IV fluids administration if the client is not able to take oral fluids, and then monitor the input and the output of this gland. So maintain skin care routines, have weight monitoring to detect any status of edema in case the gland has been on one position for too long and they're not moving well. Minimize any states of anxiety. This relates closely with disturbed self-concept. So you can look at psychological counseling, family support, open communication, diversional therapy, promote self-awareness and assertiveness. And the last bit is patient education so that the patient can understand clearly anything pertaining to their disease so that they can be cooperative enough, maintain adherence, and be on the positive end of the management. And that brings us to the last part of this session. So you can share with your friends or you can subscribe and don't forget to comment on our videos. Thank you and see you in our next classes.